It's my great pleasure to introduce today Dr. Simon Stanworth, who's agreed to give us a presentation, wasting his evening talking to us, but hopefully it won't be a full waste. Simon is an associate professor of hematology and transfusion medicine at Oxford. And I'm really glad that one of the advantages of this pandemic is that we've taken this whole seminar series virtual, and we can invite people to give us seminars who we probably wouldn't have been able to afford to fly over here from their homes. So Simon, really glad that you're able to do this for us today. And you could, you're obviously already sharing your screen, so you can go ahead and take it away.
Lovely, Dana. Thank you very much. Good evening, or I guess good morning, everyone. I recognise a few names on the list. I'm going to talk for about 35-40 minutes. Although if I'm talking for much longer than that, I suspect someone will shut me down. So there should be a bit of time for question at the end. I've deliberately kept this a fairly informal. Some of it, I guess, in the way of disclosures is going to be some of the research I've been involved with, but also it's a little bit of thinking and moving forward. You know, what are some of the gaps? Where do we want to look at things? And I guess, you know, as I've said in my first slide, the question is, you know, why should I still be interested in transfusion and research? And funnily enough, this was a question that was asked for me when I finished my haematology training in what is East London, at the Royal London Hospital, which is one of our oldest hospitals in the UK. And as is not an uncommon sequence of events, when you've finished all your training, you get summoned to see your head of department, who then asks you, well, you know, what do you want to do for your career? And I said, you know, I had several ideas. I was quite interested. Actually, I was trained in pediatrics, so mentioned pediatric hematology. I also said I quite enjoyed transfusion. And I certainly wouldn't say who it was, but he kind of looked at me as if to say, transfusion? What are you wasting your time for? Nothing, there's no research opportunities in transfusion. I suggest you go and have another think. So I guess maybe the question is, if I was giving this talk, here am I, not quite 20 years, 15 years later, would I have answered him? And, you know, are there still plenty of opportunities for us to think about in terms of transfusion research? So really, the first couple of slides are actually things fairly recently that are happening. So as mentioned, you know, I'm at the University of Oxford, and as we all do every now and again, we do these scoping exercises where we kind of think a little bit more about where some of the needs are for transfusion research, what are some of the opportunities. And one of those areas that we looked at was just thinking a little bit more about some of these groups of patients who are, well, in transfusion dependent. Certainly the hematological malignancies, anemia in the elderly, and I think some of those patients often get transfusions. And of course, there's some of the more recognized transfusion-dependent groups of patients like sickle cell. And it didn't take us long, and this diagram just summarizes, to start to realize there's still a lot of areas where I think we've got a lot of uncertainties here. What is the best way of matching red cells? I'm going to mention that in a moment. Of course, there are questions around transfusion thresholds, but I think and increasingly think of transfusion as kind of linked to supportive care. And you do need the two. You know, if you're not managing the anemia correctly, how can you engage with some of the prehabilitation strategies that are increasingly talked about by our cancer colleagues? What are the functional outcomes? What are the outcomes that matter for some of our patients? And I think there's a lot of work to be done there. And of course, although I'm only going to touch on it briefly, I think there's some real questions around iron and how we use iron. I don't think we know how to use oral iron properly. And I think there's a lot of interest in intravenous iron, but I think there's still some pressing needs there. For some reason, my slides have stopped going forward. So I don't know whether that's the internet or me. Is there anyone else controlling the slides?
No, I think you have control, Simon, but you might have to go out and go back in again. Sometimes they just get stuck.
It's not happened to me before. So I'll do that and try sharing again. Let's see if this comes up. Apologies for this. So that was the slide I was just showing you. Oh dear, we don't have a... Oh, there it is. Well, let's hope that doesn't happen again. It's just another example of, where I think there are going to be big changes in the next 5-10 years. And I know you and CBS are involved with this, but working with our colleagues in Cambridge, there's going to be a paradigm shift in the provision of matching of red cells. With genotyping can now be done at scale, can be done much more cost efficiently. And we need to be thinking about how we're going to use this, how we're going to be thinking about this in the context of our patients. And we're certainly here in the UK thinking very much around some of the patients with sickle cell disease and how we might provide better matching. What we're really doing here is moving to an era, I think, of what I've called it here in the bottom right-hand side, precision transfusion medicine. Okay, well, does transfusion research still matter to patients? So very much in the UK, when we're thinking about funding, you have to say that the research you want to do meets the needs of patients. We have to be able to say, what we're designing and what we're thinking about is important for patients. Now, there are many ways that we do that, but one of them is through an organisation called the James Lind Alliance Priority Setting Partnerships. And over the last couple of years, we've done several of these, which have been asking questions to a group of patients and carers. What matters to you? What matters to you for donation medicine? What matters to you for transfusion and use of blood components? And the other one, the one I was involved with a bit more, was around, tell us about the management of major bleeding and how important is that for you? And this just illustrates out of that exercise some of those questions that came up that were felt to be very important. You can see here the top one was, how do we stop healthcare professionals using blood inappropriately when we haven't got the evidence? Certainly a strong theme came through around wastage of blood. If it's been given altruistically, what can we do to further minimize that? You'll see here one of the third highest priorities was around the use of blood for major bleeding, and so on here. But I don't think there was any disagreement here that patients felt there's some very important areas. And I guess the final area where I'd still say is real importance here has to be around cost. And we increasingly have to look at, costs, cost efficiencies, cost effectiveness, and we still spend a lot of money in the NHS. We have a national healthcare system, but we're still putting a lot of costs around for purchasing blood. But of course, those costs don't cover costs of things like processing, cross-matching, what actually happens in the hospital. So lots of reasons here. So that was a little bit of my background to start with. What I thought I'd do in the next half hour or so, I just think about some of those questions that often come up at the moment moving forward. One of them is around red cell transfusions, one of them is around platelets, and also just want a few slides at the end to bring up that quick question about major bleeding, and in particular cryoprecipitate and fibrinogen concentrate. So first of all, let's think about red cells. I'm going to focus on randomized trials, not because other forms of clinical studies aren't important, of course they are, but there are some advantages and strengths to randomized trials, not least actually we can appraise them in a slightly more rigorous way. But we do have an advantage for our red cell transfusion colleagues, researchers, that we have now an expanding number of randomized trials. Traditionally, in fact, nearly always, these have been designed as two-arm parallel trials. They compare a more liberal strategy for red cell transfusions with a more restrictive strategy. But if the mechanisms, the processes of allocation are occurring properly, then if one sees differences in outcomes, they should only be ascribed to that transfusion policy. So we're at the moment, we're updating the Cochrane review, which we've kind of iteratively been looking at. And I think it's quite impressive. We've now got, not quite, but again, not shy of 50 randomized trials. We've now enrolled, again, around that 22,000 patients into randomized evaluations. So one would like to hope that we can start making stronger or even stronger recommendations. I'm going to summarize some of that, but what I really want to do is just think a little bit more about where this is going. And perhaps the question at the bottom of it all is, how many more randomized trials do we need of the same design, perhaps comparing a more traditional liberal versus restricted policy? Do we need to be thinking differently here and different types, different designs of studies? I think you and Canada have been at the forefront of this, and I'm going to be very brief here because there may well be now some people on this call who have more involved with these studies, but I think some fantastic studies from Canada. This was one, Jason Tay and colleagues, was published last year in the context of patients with hematological malignancies, and in this context, stem cell transplantation. Again, comparing that restrictive liberal strategy, a reasonable sample size, a non-inferiority trial, so they're looking for no benefits, and they didn't find a difference. There was nothing to suggest that there was the difference in outcomes, and so again adds to this literature, which I'm going to come on to indicate that restrictive recommendations for the use of transfusions. Some other really nice studies. This is another one from the group in Toronto, but I know it was also international, but looking at restrictive liberal transfusions in cardiac surgery. Again, compared slightly different thresholds, looked at a composite outcome, but again, didn't find any difference. It was also non-inferior, looking at non-inferiority, so whether that restrictive strategy was not worse than a liberal strategy. But what we tend to do in these reviews, you'll be very familiar with this, is that we try to pull all these studies together in these forest plots. You can see here an example of one from the currently the updated Cochrane review here. And each one of these rows represents one of those studies, and you'll see towards the bottom the David Mazur 2017 trial, which clearly is one of the biggest studies. And you can see here how we then summarize, how we do this quantitative analysis to pull it together. And this really just summarizes that for the outcome of mortality. In fact, the relative risk now is exactly 1.00. Perhaps more pertinently is look at that confidence intervals. They're beginning to narrow here. No evidence that there is a difference, a significant difference for the outcome of mortality across what is a very heterogeneous group of trials, but putting them together as a whole, we get this consistent message. No evidence that a liberal strategy which exposes patients to risk is associated with giving more blood and improves mortality. And therefore, most of us, hopefully all of us, would now advocate that restrictive transfusion policy and that restrictive transfusion approach. But what I want to do now is just think, well, hang on, where have we got to? Do we need more trials? Or are there some messages that are now coming through that might allow us to perhaps change our approaches to red cell transfusion therapy? And I think we can start to look a little bit more around the strengths of these trials and some of the weaknesses of these trials and some of the limitations of the studies for what our patients are saying. And I've been no means to say that we're the only ones doing this. I think this was a very nice figure that came out of a group in Australia who kind of pulled together some of the trials, and they just summarized some of these problems, let's call them problems, with these studies that have been done. We might be talking here, for example, about two different hemoglobin thresholds, liberal and restrictive, but actually how different in practice were those trials and those trial arms. And often it's considerably less than what might, for example, be up to 20 grams per litre if one was comparing 70 versus 90. How different was the number of units transfused in these groups? And quite a few of these studies, that difference is getting quite small. Some issues around whether, how we dealt with patients who received transfusions prior to randomization. And very rarely do trials talk, for example, about the post-transfusion target that we're looking at. And so I think cumulatively, these do start to affect how we might interpret, some of our overall messages here. I go back to the study in cardiac surgery that I mentioned earlier. This was a very nice figure reporting the hemoglobin separation between the two arms. You can see liberal and restrictive here. It's days since surgery on that horizontal axis. We're talking the mean hemoglobin concentration on the vertical axis. And you can see blue is liberal. The red inverted triangle is the restrictive threshold arm. Yes, there's a difference here, but there's a lot of overlap here between patients in these two arms. Maybe if I start to put my kind of hematology hat on, how different is something that looks like it might be just over 9 compared to just under 10? There is error in also the measurements of hemoglobin. So I think it starts to ask some questions about separation here. I think another thing that we've been interested in, and again, this is work that we've been doing with a different group, but another group in Toronto here, is I've summarized information here on mortality. Is mortality the appropriate outcome for many of our patients in these trials? Yes, it is for some of them, but I would argue not for all of them. And I think there's a really important group of patients who are transfusion dependent. Goes back to, I think it was my second slide when I was thinking a bit more about our scoping exercise at the University of Oxford. We've got very little data here on some of these patients. And I think if you ask them, what they're probably more interested in knowing is about some of the quality of life aspects, functional outcomes in these patients with bone marrow failure. And so because of the challenges of doing a randomized trial and a red cell trial in these patient groups, we did a first study, which we described as a kind of feasibility and exploratory trial. Again, you can see on that right-hand side, that hemoglobin separation between the two arms. Maybe we were a little bit more successful here about separating out these two groups of patients. We clearly weren't powered to look at quality of life, but we did do some exploratory analyses here and started to think that actually there were some improvements in the domains that we looked at in our quality of life scales for those patients in the more liberal compared to restrictive arm. And some of the analysis backed that up. Although I haven't got time to go through it, and again, maybe this comes back to questions, but if you look at that graph on the right-hand side, one of the things that we started to see coming out is that in that more liberal arm, I don't think we're seeing the same swings in hemoglobin that you might see with the more traditional approach to giving transfusions. So I don't know how familiar many of you are with transfusion therapy in these groups of patients, but often, you give 2, 3, sometimes 4, but usually 2 or 3 units of red cells on a kind of 3 or 4 weekly cycle. So you do see quite marked swings, changes in amplitude, and that might be a factor. So moving forward, what I've really started to do is I think there's some subgroups here where we just haven't got that data moving forward. And again, I think one of those is very much in the setting of cardiac disease. There's been a very nice study from a continental European group looking at restrictive liberal transfusion therapies in major cardiovascular events recently. The results were published in JAMA, as you can see here. They didn't find, and again, it was a non-inferiority trial, they didn't find a difference in the outcomes. But reading quite a lot about the discussion in this study, I think there were some questions here about the power of the study and whether it really could answer the question here. Again, note this was a non-inferiority study. And I think what's important with some of the studies that we might be seeing moving forward is that perhaps we need to be asking in some of our subgroups whether actually a more liberal approach is superior. So we might be changing the goalposts a little bit. And so Jeff Carson and colleagues are running a larger trial, over 3,000 patients with myocardial infarction. But here the question is about superiority. If we use a more liberal policy, will that have benefits, and will we see a reduction in the rate of a composite outcome of all-cause mortality or non-fatal acute myocardial infarction? I'll skip this slide. I've talked a little bit more in general about the more restrictive transfusion thresholds, and I hope I've started to indicate some of the areas where I think we've got some gaps in the research. But I want to just throw out here another what might be a kind of risk related to the use of more restrictive transfusion thresholds. And I wonder whether what we're seeing now is more anemia in some of our groups of patients. This is data from colleagues. I work with some critical care colleagues in Edinburgh, and just looking at what happens in adult critical care. And I think most of us would look at this data and would see that by the time of discharge, and this was a unit that adopted more restrictive transfusion thresholds more quickly, you do see a higher burden of anemia in that last hemoglobin value. And I suppose the questions can start to be rising, well, does that anemia matter? And again, perhaps it overlaps a little bit with those patients I was telling you with bone marrow failure, because does this matter? This was, and I know there've been other studies here, but this was a cohort study of adults hospitalized with critical illness, and it just looked at the prevalence and recovery of anemia following discharge from hospital. And you can look at these different groups of patients, irrespective of whether they had no anemia or mild anemia, moderate anemia, or more severe anemia. But it's clear here that anemia is very common at discharge, and it remains common and highly prevalent at even up to 12 months post-hospitalization. And so I think, this for me points out, this is work that we're looking at, and I'm sure others are looking at, perhaps putting more of that spotlight on anemia. These are some of the studies that I'm aware of, and there may well be others on this call who are very, have their own ideas around this, but trying to ask questions here about, what can we do for that anemia post-discharge? Is there a role for intravenous iron in some of these patients post-discharge? And I think the question of intravenous iron, is something that's certainly got a bit of a way to run here. For me, there was an important trial that was published earlier this year. This looked at, an area where most of us in transfusion medicine would consider it a very important pillar of patient blood management, that role for preoperative intravenous iron to treat anemia before surgery. This was a group that randomized, not quite, but just shy of 500 patients, and some of them got intravenous iron. They didn't, interestingly, find any benefit for their composite outcome of death or the need for blood transfusion. And I think this trial in itself would be a topic of quite a large discussion point, and certainly is worth thinking about for a journal club. I think there are some challenges with this trial. It was a very much an unselected group of patients, but what it does do for me is it starts to raise again those questions of better management of anemia, more targeted management of anemia. And again, I think we're going to see many more trials looking at this moving forward. And this, I think, is my last slide in this question, but I really just also want to raise, I think there's a lot more going on around iron. We tend to think of iron as something that's, sits in red cells, but I think the data is increasingly suggesting it has a role in innate immune responses, immune function, and even there's some data coming out around vaccine responsiveness. So I think, again, there's a lot more, we will be seeing a bit more targeted therapies and in research interests here. In the next two sessions, and I'm going to try and keep a bit of an eye on the watch here. These will be slightly shorter sections, but I've certainly been challenged over the last year by what's going on with platelets, and I want to just throw out a couple of things around cryoprecipitate and fibrinogen concentrate. I thought things were fairly straightforward with platelets. You gave them when patients got low platelet counts, you got worried about bleeding risk, and we gave them a bag of platelets. The platelet count incremented, and hopefully there was a reduction in bleeding. And we've been doing a lot of research, a lot of randomized trials in the context of hematology, largely patients with hematologic malignancies, because that's been the biggest group of recipients of platelets. But there is this other group, it's a rather diverse group of patients who also get platelet transfusions. And I think it's great to start seeing some research, more research happening in some of these other areas. And I think they're beginning to make me think a little bit more about how we should use platelets, and indeed, maybe some questions about how we should use platelets in hematology. It's, I think, fairly simple again, fairly straightforward. We're using platelets in the same way. We've been evaluating them in randomized trials, comparing liberal versus restrictive strategies. That liberal strategy may be a higher platelet count threshold, or it may be by giving a bigger dose of platelets, but the same broad principle is there. And for me, over the last 5 years, I've been working a lot, and some of you may have heard about this, in terms of a group of patients, the babies who get platelet transfusions. The platelet counts in these trials are much higher than we would traditionally use, but this is what our neonatal colleagues do. And so our trial compared 50 versus 25. I hope most of you will be aware of this, but what we found, and maybe you can say unexpectedly for many of us on the trial management group, was that in those babies randomized to the 50 group, the more liberal group, this wasn't a question of there being more benefit. What we found here was more harm. Actually, there were more deaths and there were more major bleeds. And this was statistically significant. And I think this is something that we are looking at. And I think I've talked before about this trial to some of you. But for me, this really is beginning to ask some quite important questions here about how platelets are used and what are they doing. And perhaps, just like I've been arguing, the case for iron doing much more than just being that mechanism by which we kind of grab hold of oxygen in red cells. They have much more diverse mechanisms of action. I think we now have to recognize that platelets do a lot more than hemostasis. And I think the onus is on us now in kind of transfusion to start thinking more about those immunological and inflammatory effects and what platelets are doing. I think perhaps we need to ask some of those questions more about some of the variables around the actual product we're transfusing, as you can see in the box on the right-hand side. But I do see this as an ongoing piece of work that needs to, where we need perhaps that more personalized approach to understanding who really needs a platelet transfusion and what happens after a platelet transfusion needs to be addressed. And I'm certainly, advocating this now has a little bit more relevance for us in the kind of hematology literature. Many of you will know, and this is the largest randomized trial of platelets that's ever been done. That was done in North America, in the US, a wonderful study looking at platelet dose. But essentially, it was looking for a dose effect. It was looking at a smaller dose, a moderate dose, or a higher dose of platelets. It looked at bleeding. It found no difference in those rates of bleeding, irrespective of what dose you received. So I think if you're giving a drug and you're not seeing a dose effect, you do start to ask questions about, well, what's it actually doing? And I still often come back to this graph, which I continue to share with many of my clinical colleagues, when teaching them about platelets. But, if you look at that broad range of platelet counts, morning platelet count, degree of severity of thrombocytopenia, look at days with bleeding on the vertical axis, I think it's a pretty flat curve. That platelet count is a pretty poor predictor of bleeding. I'm not really want to finish off and just move quickly to the last section and think about the bleeding. But what we found, and I think was also very much in that platelet dose study, and again, I think this is a message that sometimes gets forgotten, is these trials are also telling us that despite us using prophylactic platelet transfusions, a lot of bleeding still happens. So really there are some broader questions about, I think, the effectiveness of platelets. We need to really understand the impact of platelets. So what I want to do in the last section, rather briefly before opening this up for your questions, is just think a little bit about some aspects of transfusion therapy and major bleeding. And I'm afraid I'm very much going to have the lens here in terms of some of the research, some of the avenues that we're looking at in the UK. But, we have, things have changed so dramatically. So again, I wish I could go back to my head of department 20 years ago, where at that stage we really knew very little. We knew that fibrinogen fell, but we didn't know much more. But you think about what's happened in the last 15 years, and this table just summarizes some of those, advanced on our understanding of some of the biology, the coagulopathy of trauma. I don't think that that's related, by the way, to loss of procoagulant factors. We've started doing some fantastic randomized trials. I think tranexamic acid has led the way. And despite the fact that that paper looking at fibrinogen, we're now doing studies that are looking at fibrinogen replacement therapy. We've got a long way to go here. I think how we combine these factors, how we understand what they're actually doing in patients with bleeding. I haven't got time to go through it, but increasingly, I think many of us suspect that if you think plasma is important, it's probably not there to provide a source of procoagulants, but what's it doing? I think for us in transfusion, this trial's an important study. I don't know whether, again, it's been discussed in your journal clubs. This is the HOLT-IT trial that came out last year. This looked at tranexamic acid in patients with gastrointestinal bleeding. So very different patient group with bleeding, but different to the postpartum hemorrhage and the trauma. We're all very familiar with the trials that are telling us about a survival benefit and an impact on mortality. Now, what this trial found, and again, I haven't got time to go through all the results here, but I hope I very much just summarize them here, was that there was no evidence that there was a reduction in mortality due to bleeding, death due to bleeding within 5 days of randomization in patients with acute gastrointestinal bleeding who were allocated to the tranexamic acid group. Moreover, what this trial found was actually an indication of higher rates of venous thromboembolic events in those groups of patients randomized to tranexamic acid. Now, you may say to me at one level, okay, that's a result. That's a very important result for acute gastrointestinal bleeding. But I think it also has a broader message for us in transfusion medicine here. What we're beginning to see here is that, in essence, one size doesn't fit all for our patients with bleeding. We probably should now be starting to think about how we can adapt our major hemorrhage protocols by cause of bleeding. We're going to need different strategies for these groups of patients, depending on the indication and the bleeding. And I think here, we in Oxford, we have, and we still do have a single massive hemorrhage protocol, but we're struggling with how to think about that and how to adapt that better, in a sense, how to kind of individualize some of our treatment strategies. I couldn't help putting this up, but in fact, we were talking about it just before we started, but I thought in Canada, you were moving away from cryoprecipitate. Cryoprecipitate, I have to say, is our standard of care. So we use cryoprecipitate as the concentrated source of fibrinogen in the UK. We don't really use fibrinogen concentrate. And for me, going back to that, couple of slides ago, what we're doing at the moment is a large randomized trial. We're almost saying, let's just give cryoprecipitate up front, high dose. We're not going to wait for a fibrinogen level. We're just going to give it. So we're really changing our massive hemorrhage protocol. So we're working with all our major trauma centres in England. In fact, we just opened in Cardiff in Wales. We're looking at a trial, I think it's about 1,600 patients, and we're pretty close to the last 200, 300 patients here. But asking a more fundamental question here about cryoprecipitate, we're not comparing cryoprecipitate with fibrinogen concentrate. I know in Canada you did a large trial, I think in the context of cardiac surgery and bleeding, but we still have an interest in cryoprecipitate. And I don't know whether this will ring any bells with you, but some of my colleagues in Oxford and Aberdeen developed a kind of in vitro model to look at the roles of fibrinogen concentrate in cryoprecipitate. And these are some of the very nice pictures in this publication, which look at that kind of clot stability. This is using confocal microscopy. And I hope you can see that there seems to be a lot of evidence that cryoprecipitate may be more effective than fibrinogen concentrate. Now, of course, this is in vitro, but there are potentially important differences between these concentrated sources of fibrinogen, and I think we need to know a little bit more about how to use them. Dana, I'm just going to ask. I could stop now and take questions. What would suit you?
No, keep going, Simon. It's fine. We've got lots of time.
So I think these really might even be my last few slides here. So what I was, you can't help, and it's a bit of hesitation here. I'm going to mention the word COVID. Now, most of us will be hugely familiar with what's been happening around convalescent plasma. I'm not going to talk about that at all. But one of the queries I had, we had quite early on in COVID, when unfortunately rates of infection, hospitalizations were increasing here, there's a lot of discussion here about so-called DIC in COVID, coagulopathy in COVID. And in fact, the question I had equally commonly from many of my colleagues, but also within the blood service NHSBT here, was, will we have to think about the supply of cryoprecipitate? Again, that's what we use. But I think it then started to become a bit clearer that actually, yes, there was some evidence of coagulation disturbance here. Some people might initially have started to call it DIC, but really this wasn't a DIC. We weren't seeing the changes in platelet count, for example. And in fact, the levels of fibrinogen were often very different. But there was this question, we started to move on. Okay, well, we're not going to be worried about cryoprecipitate. But then the second issue that started to come up was really, well, we're seeing more thromboses now. And of course, that means we're going to be using heparin. We're going to, looking at different escalated doses of heparin. Could we see a consequence of that? And could we see more hemorrhagic complications? And I suppose if you have to say one of the positives that's come out of COVID, and I'm well aware they're not very many, but perhaps it has engendered some more kind of collaborative ways of doing research, and I'll come on to that in a moment. But we in Oxford worked with our adult critical care colleagues in a couple of other big centres in England, and we just pulled together some observational data here. And you can see here, yeah, these patients are having thrombotic complications, but quite a significant number of those have been, have also unfortunately had quite severe hemorrhagic complications. And for me, immediately when you start to see this data, that's why we need to do the randomized control trials here. And I think this illustrates a whole other area where, yes, it was of relevance to us in transfusion medicine here. We're talking here about an uncertain balance between thrombosis and between bleeding. How we manage bleeding is something that's very important to us in transfusion and supportive care, and we need the randomized trials. And so we were in contact with colleagues through REMAP-CAT, which I think one of these platform trials. And in fact, through that, we were put in touch with your Winnipeg group, who I think have been very much the leading. Ryan, I'm not going to try to pronounce his surname unless he's on this call, but working with them in terms of thinking about how we can deliver these randomized controlled trials. And I think it's fantastic to see these collaborations come together to answer some of these questions. You'll see, if you look for it, you can see some of the preprint results for some of these escalated anticoagulation and now antiplatelet trials. I think we should wait for the full publications. I think that's the way to be doing things. But for me, it's another illustration of how I think we in transfusion have much broader roles here beyond what might be our more conventional blood components. And so I'd like to think I could go back to my head of department 17, 18 years ago, and I could look him in the face and say, perhaps he made a mistake. I think there's still a need for research in transfusion medicine. I think we've illustrated that, beautifully over the last few years, and I think there's still many gaps. So for those of you who are still involved in transfusion, I hope I've highlighted some of those gaps, some of those areas where I'd encourage you to invest some time. Thank you very much.